My name is Yanai Porat, and I'm a fifth-year medical student at Technion, Israel Institute of Technology in Haifa, Israel. Our work is titled Predictors of Readmission Following Discharge of Patients with Gram-Negative Bacteremia, a retrospective cohort study. This work started out as part of my MD thesis under the supervision of Professor Michal Paul, head of the Infectious Disease Institute at Rambam Healthcare Campus, with additional help from co-writers Dr. Jaris Nashashibi and Dr. Itamar Poran, both residents in internal medicine. Over the last 30 years, in-hospital mortality rates of sepsis patients have been declining steadily. This trend, while praiseworthy, is accompanied by an unfortunate increase in post-sepsis morbidity and long-term complications in sepsis survivors. A decline in quality of life and activities of daily living in these patients has been demonstrated by several studies. Short-term hospital readmission is an easily measurable outcome indicating physical, personal, and other quality of life disruption in sepsis survivors. Our aim was to identify the major risk factors for readmission in the 30 days following hospitalization with gram-negative bacteremia. We were especially interested in addressing the toll of antibiotics resistance on patients' morbidity, and thus decided to focus on the effect of bacteremia caused by multi-drug resistant organisms, as we hypothesized these MDR bacteremias will be associated with a higher rate of hospital readmission. This is a retrospective cohort study including all adults hospitalized in one referral hospital in Israel with gram-negative bacteremia between 2011 and 2020 who were discharged alive. We compared between patients experiencing readmission or death within 30 days and readmissions alone on univariate analysis. Our predictor of interest was bacteremia caused by cephalosporin-resistant or carbapenem-resistant gram-negative bacteria. This variable was termed simply cephalosporin-resistant bacteria. Independent risk factors were investigated using the multivariable competing risk regression model as proposed by Fine and Gray, with the event of interest being 30-day readmission and deaths the competing event. The Fine and Gray model computes the subdistribution hazard of the cumulative incidence function in presence of a competing event that precludes the occurrence of the event of interest. This in contrast with classic Cox regression models that inappropriately censor these observations. Model performance was assessed with calibration plots evaluating the graphical agreement between observed and predicted risks at 1 to 30 days. The area under the operating characteristic curve, AUC, was calculated. Out of 2,196 patients with gram-negative bacteremias who were discharged alive and included in our analysis, 19.6%, for a total of 432 patients, were readmitted within 30 days. Another 142 patients died within this time period without being readmitted to Rambam Healthcare Campus. Nearly a third of all readmissions were for infectious causes. The mean patient's age was 70 years and half were female. The bacteremia was hospital-acquired in about half of the cases, and 26.8% of isolates tested were resistant to all cephalosporins. On two separate univariate analyses of risk factors for a combined outcome of 30-day readmission or death, and for 30-day readmission alone, we found that various demographic, hospitalization-related, sepsis-related, and pre-discharge variables were associated with these outcomes. We chose not to list all these variables here. Among sepsis-related variables, however, we found that hospital-acquired bacteremias, cephalosporin resistance, inappropriate empirical antibiotic treatment, and longer duration of antibiotic therapy were significantly associated with readmission. E. coli bacteremia and urinary tract source of infection were associated with no readmission. The rest of the text pertaining to the results of the regression analysis is explained in the next section alongside Table 1. In the main competing hazards model, 9 out of 27 variables entered in the Fine and Gray competing risk regression model were retained. The first variable, Arab ethnicity, is a correlate of comorbidities and socioeconomic status in Israel, rather than the effect of religion or ethnic origin. We realize the factor cannot be used as is outside of Israel. However, it draws attention to possible adverse outcomes in underprivileged subpopulations. Other variables included in the model were active malignancy, long-term nasogastric tube with the highest subdistribution hazard ratio of 1.83, the use of corticosteroids or other immunosuppressants, anticoagulant or antiaggregant therapy, treatment with anxiolytic or hypnotic drugs, longer duration of treatment with antibiotics, a higher median heart rate in the 72 hours prior to discharge, and finally our exposure variable, cephalosporin resistance, which interestingly enough improved the model but was not statistically significant. We conducted a secondary analysis including the appropriateness of antibiotics among 1,534 patients in whom appropriateness of empirical treatment could be assigned. In this model, resistance to cephalosporins and inappropriate empirical antibiotic treatment in the first 24 hours were significantly associated with readmission. Performance evaluation for the main regression model is shown in these graphs. Both are calibration curves obtained by cross-validation using the k-fold method. Panel A shows model performance for all 1,832 patients included in the regression analysis, with a calculated area under the characteristic curve AUC of 75.5%, indicating a good discriminatory accuracy. Panel B shows the good performance of the model in the 0 to 40% risk range, including the large majority of patients in the cohort, 1,695 patients. The model with inappropriate empirical antibiotic treatment reached an AUC of 78%. This is not shown here. In summary, readmissions and deaths among patients with gram-negative bacteremia surviving hospitalization were quite common in our study as in previous studies, and do not appear to have changed greatly in the last decade. Readmission was not related to age when considering death as a competing event. This is opposed to the finding of previous studies that younger age is associated with readmission. This implausible association is reached when censoring deaths and can be explained by the correlation of older age with death. In our multivariable survival models for readmission, with post-discharge death as a competing risk, an extended spectrum beta-lactamase or carbapenem-resistant phenotype was retained in the main model as well as in the secondary model, including the appropriateness of empirical antibiotic therapy, thus highlighting the burden of resistance beyond mortality. We believe predictive models for post-sepsis readmission can serve as decision-making and screening tools for the identification of those patients who can benefit most from post-discharge interventions to improve their recovery from bacteremia. I would like to thank Professor Michal Paul for her guidance throughout this work. I would also like to thank my colleagues Dr. Jarisna Shashibi and Dr. Itamar Poran for their important contributions to this study. And finally, here are some of the main references we used in this work. Thank you for your time.